Hi, everybody, and welcome to part 2 of our 10-part GI lecture series. This lecture is going to be on the oral cavity, and as a disclaimer before I start, the oral cavity is one of the lowest yield GI-specific sections. So if you're just studying for GI content for like a medical school specific GI exam, I would strongly consider just looking at the salivary gland tumors at the end of this lecture, and then I would continue on to esophagus and beyond if I were you, because that's way more high yield. With that said, if you're studying for step 1 or level 1, or even step 2 in some cases, I've provided a lot of content on neurology, immunology, infectious disease, and I take a more integrated approach that'll be really helpful if you're trying to integrate that content for a more broad, comprehensive exam. So let's get started. As with most sections, I'm going to do anatomy, then physiology, and then finish off with clinical conditions. So let's go with anatomy first. We have our salivary glands and ducts. There's 3 glands you need to know about in the oral cavity. There's the parotid gland, which is the largest gland, and I've highlighted it to the right. Your submandibular gland is at the angle of the jaw right here, and your sublingual gland is below the mouth. Now, each of these glands has salivary ducts that can drain the saliva that's produced in the gland and into the oral cavity. And 2 ducts that you have to know, there's the parotid duct, also known as Stenson's duct, and that's going to be located here, coming off of the parotid gland. And you also have the submandibular duct, also known as Warthin's duct, which would obviously attach from the submandibular gland and into the oral cavity. I want to briefly talk about how salivary glands are innervated because it'll kind of be a nice review for people about how parasympathetic nerves work in general, because it's the exact same mechanism no matter what parasympathetic organ you're dealing with. So how it works for a regular parasympathetic organ is that you have one of the 4 cranial nerves, either cranial nerve 3, 7, 9, or 10. They start in the brainstem and they send a signal. And that signal will first travel down a very long preganglionic fiber, okay? And at the very end of the preganglionic fiber is a ganglion, which kind of makes sense given the name. And a ganglion is just a collection of nerve cells. And this collection of nerve cells basically allows you to transmit a signal from that long preganglionic fiber to a short postganglionic fiber. And from that short postganglionic fiber, the signal can continue and finally reach the organ that you were hoping for. And in this case, it would be the salivary gland. So let's draw a picture to show this. We have our brainstem. We have our signal sent down a long preganglionic fiber. It synapses once in a ganglion, and then that signal can be transmitted to a postganglionic fiber and finally reach our effector organ. In this case would be the salivary gland, which could regulate secretions, for example. Now, the parotid gland has a little bit different pathway than the other 2 glands, so I'm just going to show that difference here so you're aware. For the parotid gland, it's actually the glossopharyngeal nerve or cranial nerve 9 that sends the signal, and that signal again will travel down a preganglionic fiber. It'll synapse in a ganglion, which is named the otic ganglion in this case. That otic ganglion will transmit the signal to a short postganglionic fiber and finally reach the parotid gland. For the other 2 glands, the submandibular and sublingual glands, it'll instead be activated by the facial nerve. And again, that'll travel down a long preganglionic fiber, which is known as the chorda tympani. The facial nerve has quite a few different preganglionic nerves, so the chorda tympani is one to know. That'll synapse in the submandibular ganglion, and then from there, depending on which gland you're going to go to, you have postganglionic fibers coming off of that ganglion into both of the different both of the different salivary glands, submandibular versus sublingual. That's it for anatomy. Physiology has a few different concepts I want you to be aware of. First off, what does saliva actually do for us? So saliva has some benefit in digestion. We have salivary amylases and a few salivary lipases that can start the process of digestion, but I want to make a point that most of our digestion occurs in our stomach, and then most of our enzymes also, especially the lipases, are produced by the pancreas. Another thing we don't think about too often with B12 specifically is that our saliva has something called R binder or haptocorin. which helps us eventually digest B12. And I go into B12 digestion in great detail in the stomach section, I believe. So if you really want to see all of how B12 absorption works, you can check that out. But here I just wanted to point out a few things. So I want to point out that we need R binder or haptocorin to adequately absorb B12. I also want to point out that R binder, like we just mentioned, it's produced in the oral cavity. And this is the most important step here. It's going to help prevent B12 degradation in the stomach. So I'm going to clear the screen and we'll talk about how that works. If we had B12 bound to an animal protein without R binder, what's going to happen is that in the presence of acid, that will dissociate. We'll have B12 hanging out by itself, and the acid will destroy that very quickly. And so we won't get any B12 that's actually absorbed. Now, if we actually have R binder or haptocorin in our oral cavity, what happens is that the hydrogen ions again will dissociate this, but before B12 can get eaten up by these hydrogen ions, it'll be bound to R binder. R binder can safely transport it into the small intestine, where B12 will later bind with intrinsic factor, and then it can get absorbed in our terminal ileum. So that's how that works. Again, if that's confusing, you can take a look at what I talk about B12 absorption quite a few times later on in the unit too. There's a little bit of antibacterial properties associated with saliva as well. It can secrete IgA, and which is the only antibody that can survive the GI tract. IgA is important for several different organ systems, so I'm just going to talk about it since this is the first time we're encountering it. How it works is that if I sent an antibody, a regular antibody, into our GI tract, what happens is that there's luminal proteases that'll come in, it'll chop the antibody in half, and you will have a non-functional antibody. The nice thing about IgA is that it exists as a dimer, which means two of them attached together, and they're attached by a J chain as well as a secretory component. And because of these two features, they can actually go to the GI tract and they can survive there without luminal proteases being able to break them down. One clinical consideration I want you to think about when you think about saliva is that Sjogren's syndrome is a disease without saliva or with decreased saliva output. And for that reason, you can imagine that you'll have an increased risk of dental infections and cavities and things of that nature because you don't have the antibacterial properties that saliva gives to us. Now let's talk quickly about saliva regulation. It's almost entirely parasympathetically regulated, which is kind of why I've already laid the framework of the parasympathetic activation, and we'll talk about that in inhibition in a little bit. It can be activated by sight, smell, or the thought of food. And so activation can occur with muscarinic agonists, which are pilocarpine and botanical are a couple examples, and it could be inhibited by muscarinic receptor antagonists like atropine and scopolamine. So let's go back to our picture. This is our parasympathetic regulation framework that we talked about already. So what exactly happens? What happens when we activate it with like a muscarinic agonist, for example? We'll have our brainstem. It'll send our signal. That signal will reach a ganglion and acetylcholine is released. That acetylcholine will bind to what's called a nicotinic receptor. And that nicotinic receptor, once it's activated, it can send a signal down the postganglionic fiber. At the postganglionic fiber, at the end of that, again, there's a section where acetylcholine is released. But this time, on the effector organ, like the salivary gland, you're going to have a muscarinic receptor, okay? Now, if we have a muscarinic receptor agonist like pilocarpine or botanical, what we can do is we can activate that receptor, that yellow receptor, directly with those medications and really stimulate the salivary gland cells to secrete more and more fluid. On the flip side, if we're going to talk about inhibition with things like atropine and scopolamine, we have the same idea where the signal gets transmitted all the way through. But this time, if we have atropine or scopolamine, what they can do is antagonize that receptor. So they will actually block that receptor so that the salivary gland acinar cells do not output as much secretion. So that's why if you give somebody a medication like atropine, they're going to have dry mouth, among other symptoms. Now let's talk about salivary gland fluid modification. Here's a picture of an acinus and a duct. We're going to see this in a few different sections, including the pancreas. So the saliva itself is secreted by these acinar cells, and you can see them right here, lining it. And acinar means resembling a berry or a grape, okay? And it kind of looks like a berry. I could see that. And these fluid secretions that are submitted are going to be initially isotonic to plasma, but later modified in the ducts. And when I talk about, I'll talk about what that actually means in a little bit. I just kind of wanted to give you that as a heads up when we move forward here. So we have our acinus, which is kind of like a berry, or acinus, however you want to say it. I've seen it in both ways, and I might use it interchangeably. And we have our duct. So what happens is saliva is produced in the acinus, it's going to be modified in the ducts, and then it'll finally be released into the mouth. Now, there's three concepts you need to know about how this fluid gets modified during its journey from the acinus to the actual oral cavity. So let's talk first about the electrolytes. So the acinus will release all the electrolytes. It'll release sodium, potassium, chloride, bicarb pretty indiscriminately. And so you'll get all of that into the duct. The duct, on the other hand, has a very preferential reabsorption of sodium and chloride. And I remember this by the mnemonic, ducts eat salt. So that helps me remember, okay, the duct is going to reabsorb the sodium and chloride. On the other hand, potassium and hydrogen have the opposite effect. The ductal cells will actually secrete potassium and bicarb back into the duct, so you'll get a higher concentration of potassium and bicarb. And this is actually physiologically important because the bicarb can protect us from all the acidic foods that we eat. So the acidic foods don't damage our oral cavity, our esophagus, and onward. Let's talk about tonicity, which just means the relative concentration of a given fluid. So the saliva is initially isotonic to plasma. And what that means is that it has the same level of electrolytes to water as our blood does. So we have water coming into the duct and we have electrolytes, and this will be the same concentration as our plasma. The problem is that our ductal cells like to absorb electrolytes, but they aren't very good at reabsorbing water. So you can see our sodium can get reabsorbed, but if we try to reabsorb water, it has a little bit more of a difficult time doing so. And so what'll happen as the concentration moves throughout the ductal cells is that you're going to get a more dilute a dilute salivary duct because water gets trapped within the duct. And so the saliva becomes hypotonic, which makes a little bit of sense if you think about how viscous blood is. If you've ever cut yourself, you notice how blood is a little bit more viscous. And if you've ever, if you notice your saliva, it's a lot more watered down. And this is why that happens. And now let's talk a little bit about flow rate. So the concentration of water of the saliva at at different flow rates varies. And let me explain that because I think I just confused myself by speaking like that. So what's going to happen with tonicity, we'll start with that. At very high flow rates, if your acinar cells are working hard and just throwing everything into the saliva and everything's moving quickly through the duct and into the oral cavity, you don't have time for those electrolyte channels, the ion channels, to actually reabsorb too many of the electrolytes. So, for example, this is what would maybe produced by the acinar cells. And normally we would be able to reabsorb a lot of this stuff. And now we have our hypotonic solution that we talked about earlier. The problem is if the flow rate from the acinus to the oral cavity is moving so fast, we might not have time for all that reabsorption. So some of those electrolytes will stay in the duct, and that'll make the saliva more isotonic to plasma at the higher flow rates. Let's talk about bicarb. Bicarb has this special feature where at high flow rates, your acinar cells are working so hard, they're producing a lot of CO2 as a byproduct, and that CO2 will actually enter the ducts, just diffuse into the ducts, and through carbonic anhydrase, that CO2 can get transition into bicarb, which will increase your bicarb levels at high flow rates. And This is, I always remember this bicarb as high carb, where at high flow rates, whether it's the salivary gland ducts or the pancreatic ducts, which I'll talk about later, at high flow rates, you'll always have high bicarb levels, okay? And actually, this is from our pancreas lecture. I'm not going to go too into detail about this. I just wanted to show you, here's the flow rate here at the bottom. So if I'm over at the right here, we're talking about a high flow rate. And you can see how bicarb, as the flow rate increases, you have an elevation in the actual bicarb concentration as well. So same as the salivary gland duct here, when we look at higher flow rates, you have a higher bicarb concentration. Now we can move on to some conditions. And the way I've structured this condition section is different than any other section you'll see in the unit. It's more of a question answer, kind of a quiz, if you will, only because it's not like I don't want to spend too much time on each one of these diseases because they're not technically GI specific diseases, but I do want to give you a framework that you can use for step 1, level 1, and then step 2, level 2, and beyond. So for lip conditions, let's talk about some lip conditions. What do you think would be the disease if you saw a pearly dome-shaped papule on the upper lip with telangiectasias? And just as a reminder, a papule is a very small lesion on your skin that's raised. So you can actually feel the raised lesion. And that's in contrast to a macule, which is a very small lesion on your skin that's not raised, okay? So if you saw this condition, you should be thinking basal cell carcinoma. And I'm going to show you pictures of them. You can see here, you can see how there's like this on the picture on the right, the pearly appearance to it, where it's kind of got this glossy appearance. And then in both of these, you can see the telangiectasias, which are just like little blood vessels that you can see in both of these images right here. And so if you ever see that, especially in the upper lip, they like to test, that's basal cell carcinoma until proven otherwise. Now, on the other hand, what if you find a firm, smooth papule with an area of central ulceration on the lower lip? Especially they like to test it on farmers or people who are out in the sun a lot. That's going to be squamous cell carcinoma. And so again, you can see this papule because the lesion itself is actually raised and it's small. And you can see the central ulceration. You can see how it kind of has this depression with this ulceration right here. That on the lower lip is squamous cell carcinoma. And a mnemonic you'll hear about how to remember which one's upper and which one's lower is that learning the lip condition cancers is just kind of BS, where B is you're going to be your basal cell on the upper lip, and S will be squamous cell on the lower lip. Moving on, what do you think would be the condition for somebody who had hyperpigmented lip macules and hematomatous GI polyps in a child? Remember, a macule means it's a small lesion, but it's not raised. And obviously hyperpigmented means just dark. This is going to be Peutz-Jeghers syndrome, which I talk about in the colon section. This is actually an exact slide from the colon section. Just wanted to show you what a hematoma just means a mostly benign collection of cells. So this is a hematoma. I believe this was in the lung. And here are the hyperpigmented macules on the lips that you'll see in Peutz-Jeghers syndrome. And a way I remember that this dark lip is Peutz-Jeghers, I think about it as people with Peutz-Jeghers look like they put Jaeger on their lips. And for those of you who are not aware, Jaeger is an alcoholic drink that's very dark in color. So Peutz-Jeghers, they put Jaeger on their lips. I don't know if that helps anybody, but it kind of helped me remember. A common lip condition that gets confused with Peutz-Jeghers, if you haven't studied it in a while, is this next one. What's the autosomal dominant disorder characterized by GI tract vascular abnormalities, painless bleeding, and it can cause arterial venous malformations? This is called hereditary hemorrhagic telangiectasia, which I talk about later as well in the colon section. Here you can see some of the telangiectasias. There's these red spot vascular abnormalities in the lip, and then you can see them on the tongue right there. So that's something to keep in mind. Very different from Peutz-Jeghers lip pathology, but if you haven't studied it in a while, you might get those confused. This one's a tough one. I don't expect many people to get it. What vitamin deficiency would be seen in a very, very malnourished person with blurred vision and scaling or fissures at the corners of the mouth, excuse me. This is how they like to test vitamin B2 or riboflavin deficiency. If they're going to test B2 specifically, they definitely will give you the chelosis here if they're trying for B2. I guarantee. I've never seen an answer of B2 that didn't have this chelosis. So just keep that in mind. And you can see it right here, this chelosis, these angling, the fissures at the angles of the mouth. Now, what's the classic disease that presents with painful vesicles on an erythematous base in the lips and the oral mucosa, also known as that classic dewdrops on a rose pattern? That is HSV infection, specifically HSV1. So for the mouth, you want to think of HSV1. And for genital herpes, you want to think of HSV2. That's not always true in real life, but for tests, they pretty consistently will give you HSV1 for the mouth and 2 for the genitals. It's a double-stranded DNA. And another thing they like to test about all the herpes conditions, they can remain dormant in the trigeminal nerve dorsal root ganglia. Again, we talked about the skin findings, and let me show you a picture of that right now. You can see these dewdrops right here. I know the picture quality is not the best. And then it's on this erythematous base. You can see how red it is. And some complications that they really do like to test on boards. They like to make sure that you know that temporal lobe encephalitis is associated with herpes, with HSV. Oftentimes you'll have a presentation with somebody with a seizure, and they'll show you a CT scan of it, which I have a picture of later, and they really want you to know, hey, that's a herpes infection. You could also get infection of your eye, keratoconjunctivitis, and herpetic whitlow, which is where you get HSV1 on your finger, and that could be somebody like a kid who's messing with his cold sore too much, or it's found in dentists who have to, use their fingers inside other people's mouths a lot. And so you can see, first complication I'll show you is this medial temporal lobe encephalitis right here. And like I said, you'll see it classically on a person who has a seizure. They'll give you an MRI, a CT scan or an MRI, which will show this lesion in the medial temporal lobe, and you'll have to deduce, okay, that's probably HSV1. And then here's herpetic whitlow, which is just a complication of herpes that spread to the finger. Last lip condition I'll talk about is what's it called when somebody with congenital syphilis has fissures along the angle of the mouth and the nose? That's called Raygade's. Let's move on to some oral mucosa conditions. What's a painful gray-white ulcer with a red border associated with stress, local trauma, and several autoimmune diseases? These are called canker sores. But they like to say aphthous ulcers if you're taking a test. Now, canker sores are really painful. You can see one right there to the right. And you can see it's gray-white, and it's got this red, angry base around it. And again, induced by stress, and it can resolve spontaneously, but they often recur, and they're associated with many autoimmune diseases. Let's talk about some of those autoimmune diseases now, just so you can kind of get your brain rolling in a more integrated approach when you hear aphthous ulcer on a test. So what if you have an aphthous ulcer in a young adult with weight loss, abdominal pain, and chronic bloody diarrhea? I hope you're thinking about one of the inflammatory bowel diseases like Crohn's or ulcerative colitis. In our colon section, I go into great detail on the differences and similarities between these two diseases, and this is from that section. And here at the bottom, I just want to point out the extraintestinal manifestations that can happen with both of these diseases, and we have aphthous ulcers right here. Okay? How about if you found cold sore or canker sores in a young female with fatigue, abdominal pain, steatorrhea, which just means fat in the stool, often caused by fat malabsorption, iron deficiency anemia, and a new skin rash. So what's going on there? That's celiac disease, which again, I talk about in great detail in the small intestine lecture. And this is the rash that I was talking about. This is called dermatitis herpetiformis. And it's called herpetiformis, but it has nothing to do with herpes. It just looks kind of similar, which is how it got its name. It's actually due to the same antibodies that cause celiac disease. Sometimes those antibodies and IgA can get to your skin. And once they get to your skin, your immune system will respond to that and cause a big inflammatory reaction. And so you'll see all these blisters on your skin. How about an autoimmune reaction, an autoimmune disorder, excuse me, of aphthous ulcers in a female who has a classic facial rash, arthritis, pancytopenia, pleuritic chest pain, and a positive ANA. So if you haven't guessed, that's lupus. Lupus can present in a ton of different ways. I'm not going to go into lupus for in a GI unit, but here's just a mnemonic that I always use to remember all the symptoms of lupus. And I want to point out that there you go, oral or nasal ulcers are a part of lupus. So don't forget about that. If they give you oral ulcers, I don't want you to just think GI, GI, GI. It could be quite a few other things. And last one associated with aphthous ulcers that you need to know. If you have somebody who comes in with aphthous ulcers, painful genital ulcers, painful shin lesions, fevers, and uveitis, especially, they'll always give you this, a young male of Turkish or Mediterranean descent, and it has a strong association with HLA-B51, that we're looking at Behçet syndrome. And now I'm going to talk a little bit about Behçet syndrome here, but not too much. It's an immune-mediated vasculitis, so it's an inflammation of your blood vessels. And like I said, it's associated with HLA-B51. We already talked about young males, Turkish or Mediterranean descent, and all the lesions that all these symptoms that we just talked about are the same. The only thing I want to point out is I said painful shin lesions. That's erythema. That's classically called erythema nodosum, is that. And the blurred vision might be due to uveitis. So something to keep in mind. A little bit more about oral mucosa conditions, but no longer talking about canker sores. What if you see somebody with white striated oral lesions in a sexually active male with hepatitis C? If you guessed it, that's lichen planus in the mouth, also referred to as Wickham striae. If you check out our liver lecture later on, you'll see I talk about hep C and all of its different complications, like the cryoglobulinemias, the lymphoma you can get, all the kidney diseases. But one of them is this rash here, and you can see Wickham striae located right here in the mouth. What if you have somebody, which vitamin would be deficient here? Gum bleeding, petechiae, which are little bleeding vessels, usually indicative of low platelet count, and perifollicular hemorrhages in an elderly woman on a tea and toast diet. They love this tea and toast diet. I don't know why. This is scurvy or vitamin C deficiency. Let's move on to the next one. What if you find a bright red spot with a blue-white center in the buccal mucosa or the gums in an unvaccinated child with a cough, runny nose, and conjunctivitis? If you guessed it, these are describing COMLEX spots, which are found in measles. I'll show you a picture of them right here. So again, bright red spot with a blue-white center in the buccal mucosa. Often called, if you ever see something that kind of looks like grains of salt in the gums, that's a pretty good sign. You can see one right here, this bright red spot with this blue-white center. And so measles, just remember measles, it's a negative sense RNA, and it classically presents with the 4 C's. You have cough, coryza or runny nose, conjunctivitis, and COMLEX spots, which may not start with a C, but we're going to assume it does for this mnemonic. And just remember also that it has a maculopapular rash, which is not as exciting for the mnemonic, but it's still important to recognize. And I've seen this tested. I think I had one question before on this, so it's not super common, but they do like to say, hey, this kid had measles a long time ago, and now they're coming in with another disease. Think about this subacute sclerosing panencephalitis, which is like a neurological condition. Like I said, I've seen it once, so it's good to kind of know. They can also get something called giant cell pneumonia. And treatment is really important. They love to test how do you treat this, and you treat it mostly supportively, but you give vitamin A has actually been shown to improve, be an effective treatment for measles. Okay, moving on to what if you saw an adult female complaining of dry eyes and difficulty eating foods? This condition's associated with pernicious anemia. We also saw it earlier associated with dental infections and cavities. And you probably got it at Sjogren's syndrome. What if you see painless violaceous lesions on the hard palate, arms, and legs in a patient with HIV? That's describing Kaposi sarcoma, which I'll show right here. Let's keep moving on. What if you find a hyperkeratotic oral mass in a smoker or alcohol user with odynophagia, which just means pain with swallowing, and weight loss? That's also describing squamous cell carcinoma, but this time it's not on the lip, it's going to be inside the oral cavity. And last one, this one's very tough, but I'm still going to give it anyway, just so you're aware. What if you find a genetic condition which genetic condition is associated with mucosal neuromas, marfanoid body habitus, pheochromocytoma, and medullary thyroid cancer? This is MEN2B syndrome. I talked about all the MEN syndromes in the pancreatic unit, and so here you are right here. Just want to point out that the mucosal neuromas, very, very low yield. I think the MEN syndromes in general are somewhat low yield, and of those, I think this is probably the lowest yield one, but I kind of give you some good mnemonics to make the MEN syndromes easier, so I check the pancreas unit out if you're interested in that. And moving on to the teeth now. So the teeth. So what bacteria would cause subacute endocarditis following a dental procedure? Those are the viridans streptococci. And so oftentimes they won't say, hey, it's a viridans strep. They'll put strep anguinosis or mitis or mutans or sanguinis. And I've seen all four of these tested. So you really do have to know each of these four can be the causative agent in subacute endocarditis after a dental procedure. What are the notched incisors called for somebody with congenital syphilis? Those are called Hutchinson's teeth. And you can see them right here, these notched incisors right here. I've never seen a picture of it, but I've heard them describe a kid with notched incisors, and you have to know it's congenital syphilis. How about defective molar seam? Those are called mulberry molars. That's tough to say, mulberry molar. Anyways, here's some mulberries if you've never seen them before, and you can see the molars themselves actually have pretty similar appearance to these, so I can see why they were named that. Again, associated with congenital syphilis. Which antibiotic is associated with teeth staining and avoided in children in most circumstances? That's going to be your tetracyclines, okay? And just remember that. And there's one disease that you actually still give tetracyclines in children. Dude, I don't know, I didn't write it down, but that's Rocky Mountain spotted fever. In other conditions like Lyme disease, you avoid tetracyclines in kids and you give them something else like amoxicillin. And then you can give tetracyclines to people in their teens and adults who have Lyme disease instead. Something to keep in mind. And last tooth condition, which recreational drug is associated with poor dentition, skin picking, insomnia, loss of appetite, and heart failure? And if you guessed it, those are methamphetamines. Let's talk a little bit about tongue conditions. We have a few different subcategories here. What's it called when you have inflammation of the tongue? It's not a trick question. It's just called glossitis. Which vitamin deficiencies, I should say, are associated with glossitis? There's quite a few, actually. Iron deficiency, pernicious anemia, which is B12 deficiency, and then all the other vitamin. I guess it's a little redundant with B12 here, but any B vitamin and iron you should consider can be associated with glossitis. And with that, what's a condition associated with iron deficiency anemia, dysphagia, and esophageal webs, in addition to glossitis and angular cheilitis? That is Plummer-Vinson syndrome, which I talk about in the esophagus lecture. I just want to point out right here, glossitis is one of its conditions right here. So something to keep in mind. What's an enlarged tongue called? Again, not a trick question. That's referred to as macroglossia. Let's go over some conditions, especially childhood disorders that also have macroglossia. You can get what is it called? Which syndrome is it when you have macroglossia in a newborn with upslanting palpebral fissures, a single transverse palmar crease, and brush field spots? That's Down syndrome. What about if you had macroglossia, delayed bone growth, intellectual disability, a protruding abdomen, and abnormal reflexes in a newborn who never received any prenatal care. This one's a little trickier. This one is congenital hypothyroidism. I always remember that as it has a protruding tongue and a protruding abdomen. They always like to give the abdomen and the tongue within the description. So whenever I see both of those, I start to really consider congenital hypothyroidism. And so here's a picture of it, sorry about that, of the protruding tongue and the protruding abdomen. Last one, tough one, but I have faith. Macroglossia in a newborn with Wilms tumor, hemihypertrophy, which is where one of your arms or legs is longer than the other or wider than the other. You can get omphalocele, which I talk about in the small intestine lecture, I believe. That's where your abdominal contents have actually herniated out at birth. And enlarged visceral organs. This is a rare disease called Beckwith-Wiedemann syndrome. And I remember Wiedemann by the wide component. You get wide organs, like enlarged visceral organs. You might have one wide arm or one wide leg with this hemihypertrophy. Your abdomen's so wide that it's pushing out and you causing an omphalocele. Or you can get a Wilms tumor, which would obviously make your abdomen or your kidneys wider as well. Again, pretty low yield, but that's just a nice mnemonic if you ever do get tricked up by that one. Okay, so let's talk a little bit about plaques now. What's a white plaque on your tongue that can be scraped off? You see it a lot in people with HIV or other immunocompromising conditions. That is thrush or oral candidiasis, which I've shown here. Remember, you can scrape it. They love that. And you treat it with nystatin. Nystatin, I'm just going to give you the mechanism because I don't know why. I've seen a lot of test questions on antifungal mechanism of action. So just don't get tricked. Nystatin, what it does is it actually just binds ergosterol and it'll form pores in the cell membrane. So it's kind of a cool mechanism. And it's the exact same mechanism as amphotericin B. Okay, so those two, just remember those antifungals, they like to punch holes in stuff. What if you found a white plaque on the tongue that cannot be scraped away? And this lesion is actually precancerous and can progress to squamous cell carcinoma. This is called leukoplakia, which you can see right here. Remember the difference between the two? You cannot scrape away leukoplakia, but you can scrape away thrush, okay? What about leukoplakia that is on the side of the tongue? It's seen in immunocompromised patients related to EBV, and it's actually a benign condition, okay? This is called hairy cell leukoplakia. So again, you can't scrape it off, but it's on the side and it's associated. I've seen this before and they like to test it where they show this and they say, what's it associated with? And it's EBV infection. How about a red plaque on the tongue caused by dysplasia and has a high risk of progression to a squamous cell? That's erythroplakia. And you can see that right here. And that already looks cancerous to me. That just looks bad. Okay, last little section on tongue conditions. What if you saw a kid, the question talked about a kid who has a strawberry tongue, pharyngitis, a sandpaper rash, anterior cervical lymphadenopathy, and a risk of rheumatic fever or PSGN. I guess if I say what PSGN is, it gives it away. That's a group A strep infection. And PSGN, yeah, it's post-streptococcal glomerulonephritis, so a kidney disorder following a strep infection. Now contrast this with the next presentation. Oh, actually, scratch what I just said. Let's look at what a strawberry tongue looks like. So this is a strawberry tongue. You can see that in group A strep and a couple other disorders. And you can see the sandpaper-like rash, okay? Now, contrast that with this. What if you have a child with a strawberry tongue, but they also have prolonged fevers, conjunctivitis, they do have a rash, they have cervical lymphadenopathy, they have palmar erythema, so their hands are red, a new cardiac murmur, and you usually treat this disease with aspirin. Anybody know what that is? That is Kawasaki disease. Here's Kawasaki disease. There's a strawberry tongue. The mnemonic, a good way to remember Kawasaki disease is the crash and burn mnemonic. I really like that. I think it was in first aid. You have conjunctivitis, you have a rash, you have adenopathy, a a strawberry tongue, you have hand problems, and then the burn is the fever. You have to have a fever lasting at least 5 days, okay? And I guarantee you, if you look back at any test question that's had Kawasaki's disease in the past that you've seen, they've always mentioned this fever lasting a long time, 5 days. And something else they've always mentioned is this conjunctivitis. We don't think about this, but I can't remember who told me. I think it was an ER doctor. They said if you ever want to know the difference between Kawasaki disease and group A strep, either in real life or on a test, look at if they have conjunctivitis. If they do, it's Kawasaki disease. If they don't have conjunctivitis, it's group A strep. Kind of an interesting thing. And it's actually held true when I've checked back to some of the questions I've gotten wrong in the past. Just keep that in mind. And you treat it with aspirin or IVIG or steroids. And you always have to remember, they love this test question. The complication is a life-threatening aneurysm. So you always have to follow up with echoes for people with Kawasaki, okay? Anybody know what it's called when you have choreiform, which kind of means just like random sporadic tongue movements in a patient with schizophrenia? And you treat this condition by stopping the antipsychotic, or you have to switch medications, or you can give them tetrabenazine or deutetrabenazine. This is called tardive dyskinesia. It's one of the late reactions to prolonged antipsychotic use, especially the typical antipsychotics. Let's move on to the tonsils and the oropharynx real quick. What if you saw a kid who had pharyngitis as a child, anterior cervical lymphadenopathy, and the condition also has an association with valvular abnormalities if left untreated? It's not a trick question. This is also group A strep. That valvular abnormalities, that rheumatic fever we talked about earlier. So it's the same thing. And you can see one thing, this is more applicable to step 2, I believe, maybe even step 3, but it's definitely step 2 more than step 1, is the Centaur criteria, okay? This tells you, basically gives you an idea as a provider. If somebody comes in and you're like, I don't know if I should treat them for strep or if I should test them with a culture or should I just leave them be? This helps you get an idea of how likely it is that they actually have strep throat. And so the Centaur criteria, you get 1 point for each of the following. Absence of a cough. So you should, if you don't see a cough, you get a point because strep throat does not cause a cough. If you have tonsillar exudates, like the ones that you can see to the right, that gives you a point. If you have tender lymphadenopathy, you'll get a point. If you have elevated temperature, like a fever, you get a point. And this is kind of an interesting little subcategory here. Because strep throat's so common in young kids, if you're less than 15, you get a point. But if you're over 44 years old, your risk of strep throat's so low that you actually deduct a point, okay? And then you calculate it up. And if your score is 0 to 1, you usually don't give an antibiotic. You could still culture it, but from the testing perspective, usually if it's 0 to 1, you don't give an antibiotic, you don't culture it. If it's 2 or 3, you should get a wound culture if you're still suspicious, and then you provide an antibiotic after if it's positive. And then if the Centaur score is 4 or higher, you should treat it without even requiring a wound culture. In real life, this doesn't happen. Like if you have somebody who has all these symptoms, even if their Centaur scores 4 or 5, you're still going to get a rapid strep test. You might as well just to confirm it, just to make sure that you're treating the right thing. But for tests, they do kind of like this: 0 to 1, nothing to be done; 2 to 3, wound culture usually, and then 4 or higher, you just treat it. What I like about this Centaur criteria is that there's an awesome mnemonic that I don't take any credit for, but it's really nice. So check this out. So the Centaur criteria actually it's in the name. So the C stands for the absence of cough. The E in Centaur is the exudates. The N is the lymph nodes. The T is the temperature. And the OR is our OR category, where you can get a point if you're less than 15 or minus a point if you're greater than 44. This is not useful for your GI unit. And it might not even be useful for step 1 or level 1, but I don't know. I think it's such a cool mnemonic, I had to add it in for you guys. All right, what if you find a pharyngitis in a teenager who has posterior cervical lymphadenopathy, and this condition is associated with the risk of splenic rupture? Yep, that's mono, if you said, mononucleosis. How about what class of viruses cause pharyngitis atypical pneumonias, and hemorrhagic cystitis. The pneumonia is often in close quarters, and we have a vaccine available for those in the military. That is adenovirus. What if you have a pharyngitis in an unvaccinated person with pseudomembrane formation, severe lymphadenopathy, and there's also a risk of myocarditis or heart failure? So this is caused by diphtheria. So diphtheria, I have a couple pictures on the right there. It's a potentially life-threatening condition. You're on a test, you'll always see it in an unvaccinated person, and they'll specify that. They'll tell you. And this will present with pseudomembranes in the throat. You can see it right here. You can see severe lymphadenopathy, sometimes referred to as bull neck lymphadenopathy. You can see this really severe lymphadenopathy over here. And you can even get myocarditis and death in certain cases. Okay, so let's talk about the mechanism of diphtheria, because this is something that is very, very high yield for step 1 and level 1 especially. And it's always nice to have a refresher on it because I forget it sometimes. So diphtheria, the toxin is encoded by a beta prophage. And so what is that? That's actually a virus that infects diphtheria. If you have Corynebacterium diphtheria floating around without being infected by this virus, it's not going to give you this it's not going to actually give you this really, really severe diphtheria picture. So what happens is that we have diphtheria. A virus is going to come in and inject its own genetic material inside of diphtheria. So you'll actually have the viral material within here now. And that viral material can then release the exotoxin that affects our cells. So how does that work? So we have an infected Corynebacterium diphtheria, right? That's going to be able to finally release these diphtheria exotoxins, and these exotoxins will enter our cells. Our cells are busy with our ribosomes and our amino acid chains right here, our developing protein. What these exotoxins do is that they can actually inhibit this whole synthesis by this pathway. And this is the exact same mechanism that Pseudomonas exotoxin A uses to cause a lot of its problems. And so again, on the tests, they love this stuff. They love to give you a picture where they describe somebody with classic diphtheria, and you know it's diphtheria. And then they say, the exotoxin of this disease has a similar mechanism to the exotoxin of which bacteria. And then you'll have to not only know that it's diphtheria, but you'll have to know it has the same mechanism as Pseudomonas. And I don't guarantee it, but highly likely you'll have a question on this specific mechanism. So to diagnose it, you just have to know that they are gram-positive rods. You can see them right here. And I don't know if this will help you. It's when I studied for step 1, I had a mnemonic for all the gram-positive rods because micro is so confusing. And I'll just share that right now. You can turn away from the screen if you're kind of sick of this lecture, or you can move on to the esophagus, and I promise I won't be mad. For the gram-positive rods, I always remembered it with my alphabet mnemonic. You know how we sing A, B, C, D, and then you kind of do the L, M, N, O, P, right? So I remember that. To remember the A, B, C, D is actinomyces, bacillus, clostridia, and then diphtheria, which we're talking about right now. And then for the LMN part, I remember listeria, mycobacteria, and nocardia. I don't know if this is helpful, but at least maybe if you saw a gram-positive rod in the question stem and you look at the answers and you don't see anything with A, B, C, D, LMN, maybe that'll at least rule some of those out for you. I'm not sure. Take this for what you want. Okay, and then they like to make sure that you know it can grow on Loeffler's media and tellurite agar. And the last thing they like you to know is that the ELEC test is what actually identifies the toxin. Okay, we've talked way too much about diphtheria in a GI lecture series, but that's okay. We'll move on. What if you find a child with severe acute dysphagia, drooling, fevers, he's in the tripod position, there's a thumbprint sign classically on x-ray, and this can be a fatal disease. It's very rapidly progressive. This is epiglottitis caused by Haemophilus influenza. You can see a picture on the left. They probably won't show the picture to the left. They like to show the picture on the right because they like this thumbprint sign. They love that. Epiglottitis. Don't forget that. What if you see painful blisters affecting infants and children? Usually during the summer months, caused by Coxsackie A virus and self-limiting. This is Herpangina. Like I said, it's self-limiting, but it can prevent some children from eating and drinking enough because it's so painful. So that's the only thing you really have to monitor with that. Otherwise, completely benign. What if you find an adult male who develops a severe fever, drooling, and odynophagia? Remember, that's painful swallowing. Days after having a fishbone stuck in his throat. This condition also may progress to acute necrotizing mediastinitis. Very rare, very, very rare, but it's a retropharyngeal abscess. And honestly, I could have given you the physics. What will happen on a presentation is that they might mention somebody who, choked on some food, but they'll definitely mention, hey, on this physical exam, you can see this mass in the back of the throat or something. They'll say something like that. I was kind of playing a little hard to get there, but that's something to keep in mind. Very low yield, I'd say. Maybe more of a step 2 or like a surgery specific thing on your shelf, but I wouldn't worry too much about that one. And just kind of a fun one. Most common cause of snoring in children. Anybody know? This might be on your peds shelf, otherwise it's useless. Tonsillar hypertrophy. So your tonsils can get too big, can cause snoring. And sometimes that's why they remove them. Okay, now let's actually talk about what you all came here for. GI stuff, right? So salivary gland stuff. You can get sialolithiasis, sialadenitis, and salivary gland tumors. Okay, so sialolithiasis, the tongue twister word. So just as a reminder, what a monolith is a single stone. So lith means stone, right? We have kidney stones, it's nephrolithiasis, gallstones or cholelithiasis, and saliva stone is sialolithiasis. So these are usually located so they can be located anywhere, but they like to make sure that it's most commonly in Warthin's duct. So here's Warthin's duct, boom, salivary stone. Risk factors, they make sense. If you're dehydrated, you're not having as much of a dilute saliva, a hypotonic saliva, you can get it. You can have local trauma that might injure a part of the duct, and then a stone can start to form there. And your symptoms are going to be pain that worsens with eating. That should make sense. As you eat, you produce more saliva. So that's all that stuff is going to push against that stone and cause inflammation because it can't get through. And you treat it with a few different things. You can massage it. You can give hydration, makes sense. And you could also give pain support. So now let's talk about sialadenitis, which is just inflammation of the salivary gland or ducts, right? Anything with itis, just think inflammation. And this can be usually related to bacterial overgrowth, secondary to saliva stone. I'm going to stop saying sialolithiasis because I can't say it anymore. So I have our pathogenesis written up here. So let's go on exactly how that happens, right? So what happens is that you first get saliva stone. I almost said it. That was close. So we have our acinus in our duct, and you get a stone that's obstructing the duct, right? Next thing that happens is that things try to get through that blockage, and debris and inflammation starts building up behind it, right? So you have all this thing pushing in it, and you get this debris buildup. Normally, bacteria is also excreted out of there, but in the case of a stone being in the way, bacteria starts to grow behind it. So you get bacteria growing, and most of the time it's Staph aureus, but you can also see anaerobes as well for saliva stones and saliva stone infections, okay? Now, a specific subtype of sialadenitis is parotitis, and the real thing you have to know about parotid gland inflammation is that it's associated with mumps, right? So you're gonna, again, you'll see a classic presentation of a child who wasn't vaccinated and they have all these symptoms. They can get meningitis, they can get orchitis, which is inflammation of the testicles, giving you sterility potentially, and pancreatitis. And I remember mumps by the mnemonic mumps, where the first M is just mumps, keep it simple. Then you get orchitis, meningitis, pancreatitis, and then for parotitis, I remember it as a salivary gland inflammation or involvement. Okay, last section here, we're almost done. But this is probably, if you're taking the GI unit, this is the high yield section that I would pay attention to. There's only 3 tumors I need you to know. There's 2 benign ones. There's a pleomorphic adenoma and Warthin's tumor. And for malignant tumors, there's Mucoepidermoid Carcinoma, okay? Let's start with the Pleomorphic Adenoma. So this pleomorphic just means it's kind of like a shape-shifting tumor, okay? It can assume many forms. And an adenoma is a benign tumor. So that's why it's called a pleomorphic adenoma combined is a benign tumor that can assume many forms. And remember, like we have other adenomas. You have like hepatic adenomas, colorectal adenomas. They're all benign, but some of them do have a chance to eventually transform into something malignant. So that's always something to keep in mind with all these adenomas. So you'll see a mobile, painless mass, usually at the angle of the jaw in the parotid gland, okay? Important to remember it's mobile and painless because it hasn't invaded into the nerves and it hasn't invaded into the connective tissue. When we talk about mucoepidermoid carcinoma, the malignant salivary gland tumor, it's very painful and it's usually immobile because it's already buried deep within your connective tissue. So that's a really good differentiating factor when you're thinking about, is this benign, is this malignant, which tumor is this? Prognosis is great, but like I said, as with a lot of adenomas, there's a small risk of malignant transformation, so you usually have to take it out. And unfortunately, with this type of tumor, it does come back often. I'm going to show you the histology, which they do like to test on, actually. So pleomorphic, when we just talked about pleomorphic, we talked about able to assume many forms. And this typifies what it looks like on histology. They sometimes describe it as chondromyxoid stroma, which is very confusing. Also might describe it as a mixture of epithelial and stromal cells. I've seen that description on a test question as well, because sometimes they won't give you the slide. They'll just give you a description of what the pathology slide would look like. What that means, so epithelium, we're going to see a lot later on when we talk about like our simple columnar cells that line our stomach and our intestines. Those are just cells that line glands, okay? And so in the example, we've already seen our acinar and ductal cells that line our salivary gland. Those are all types of epithelial cells, and they're very tightly packed, okay? And you can see them on the left here, tightly packed cells. And in contrast, the stroma is our connective tissue. It's a lot more free-flowing. There's a lot more open space in there with cartilage. So you can see that on the right here. So if they ever describe, if you're talking about a salivary gland tumor, and they're talking about a benign tumor that has a lot of different types of cells within it, consider this pleomorphic adenoma, okay? Warthin's tumor is also benign, and it's, I don't know, I've never seen this on the test, this papillary cyst adenoma lymphomatosum. I put it in there because one of the resources, I can't remember if it was First Aid or Boards and Beyond, mentioned it. It can be referred to as that. They usually call it Warthin's tumor, thank God. And it's a benign tumor as well, also on the parotid gland. Big risk factor is smoking, and they will tell you that this person's a long-term smoker. I guarantee you that. They will, if it's Warthin's tumors, the answer, they will mention smoking. You can see cysts. You can also see a ton of lymphocytes and with germinal centers. So you can see the lymphocytes here, these dark purple dots that are all around the entire slide, actually. And you can see these germinal centers right here too. So they might describe that. For Warthin's tumor, I remember it by thinking about Lieutenant Dan from Forrest Gump. If you haven't seen Forrest Gump, you should. If you have seen Forrest Gump, you should watch it again. I remember it because Lieutenant Dan, we know he went to war. That's how I remember it's Warthin's tumor pneumonic. He always smoked in that movie, right? You'd always see him with a cigar in his mouth. So that's how I remember smoking's a risk factor. He was a protagonist in the movie. He had his, his goods and bads, but he was definitely a protagonist. So that's how I remember it's benign. And then I remember, obviously, Lieutenant Dan, he gets injured and he wants to die, but he ends up getting a lot of medical attention, much to his chagrin. And I remember that all that medical attention is kind of like the abundant lymphocytosis that we see on the histology slide. Excuse me. And for malignant tumors, I think of mucoepidermoid carcinoma. So this is the most common malignant salivary gland tumor. It's also located in the parotid gland. So as you can see, all these three tumors I talked about, they're all parotid glands. So that's not really going to help you differentiate any of the three. The big differentiating factor between mucoepidermoid and the other two is going to be how it presents, right? It's going to involve the facial nerve, which is not common. The other two don't involve it because they don't invade into any nerves. They're benign, right? It's also going to be associated with a lot of pain for that same reason. It's going to cause a lot of pain because it's invading into these pain fibers. It's going to be immobile. You can't move it around because it's invaded deep within your connective tissue. Okay. And histology, you're going to see mucinous and squamous components. You can see the mucinous to the left and the squamous to the right. I don't think the histology slide's that important. You can kind of tell that these cells are a little angrier than the cells that we saw in the benign tumors. I would really take away more about the presentation. Immobile, painful. If you hear those two words in a parotid gland tumor, I would be picking mucoepidermoid carcinoma the vast majority of the time. All right, I think that's it for this section. Yep. So that's the end of this section. I always like to have a quote at the end. This one's from Einstein. Try not to become a person of success, but rather try to become a person of value. So just think about that. It's not about how well we do on these tests all the time. It's good to study, but always keep that extra picture in mind. All right, that's it for me for this one. I'll see you all for the esophagus shortly. So thanks for watching.